So that's where we'll go. I'm going to cover some real basics, not because I don't think you've got the basics, but in case one of you doesn't. The biggest problem is most people don't understand that you have to do 4 things in parallel, and you have to do 4 things in parallel in information governance. It's not one or the other. You have to do them all. So I'm going to cover that, and then we're going to move quickly on to my colleagues who are sat here, who are going to do the real business of telling you what's really happening in the world of informatics and information governance around opt-out and things like that. And I've got a bit of a video with Dame Fiona that I want to show you. So, the legal basis of sharing. This is called the Diamond of Delight. It's really easy, and this is the way you learn about information governance as a clinician. And if you learn this, you're 85% of the way there. All right, so it's really easy. So the first thing you have to understand is the Human Rights Act. Article 8, you've got a right to a private life. So when somebody says, oh, we want to change the way people live, and we're going to collect all the data and we're going to change the way they live, just have a little thought to human rights. Am I invading someone's privacy? All right, so just have a little thought about that when somebody suggests all the changes to where people live. The other thing is your own legal context. You work for an organisation. Are you supposed to be doing what you're doing in terms of the construct? So it says nothing in the Health and Social Care Act of NHS Digital, for example, becoming a major supplier of IT unless we're directed. All right? So we can't just go off and decide, oh, we're going to do stuff. We have to be directed to do stuff. So check out whatever organisation you work for. Are you supposed to be doing, or could you explain what you're doing by the legal construct? If you're a provider, you're a CCG, can you justify what you're doing? So those are the 2 easy things. All right. Just make sure whatever you're doing. If you're doing it at work, you're doing it within your statutory basis. And if you're starting to invade people's private life, just have one thought. Just one thought towards the Human Rights Act. That's all you need to think about at this stage. Clinicians. People tell us secrets. The relationship between you and me in this room is you're my audience. When you're sat next to me in a consultation room, you're telling me your secrets. So how do you justify sharing? Okay? So what you tend to do in a consultation is say, oh, Tim, look, I'm pretty sure you've got an ulcer. I'm going to refer you to a gastroenterologist, and I'll write to him today and get that sorted out. And Tim says, okay. Or, no, I'm really frightened of a scope going down. I don't want you to refer me. So you've got a set of consent dialogue going on there already. So what are the ways of handling the common law duty of confidence? So consent. So you can only rely on implied consent as you do in your consultation if it's within people's reasonable expectations. So think of your uncle, your auntie, all right, and think, would they expect me to be doing this under the common law duty of consent? All right, that's where you need to be. Otherwise, you need explicit consent. So Fiona said, for sharing a whole record, you need explicit consent, for example. All right. So where you're not sure, implied consent applies. You need explicit consent. Okay. So that's number 1. 2, statute. Okay. I, as NHS Digital, if Secretary of State directs me, I can require you to give me the data. It sets aside the common law duty. Okay. So statute is another way of getting around the common law duty. The third way is a court order. You get a letter from a judge saying, give me the data on Martin Severs and what he was doing, or what he's been to see you about for the last 3 weeks because of A, B and C. You've got a court order. It's there, there's a legal document, you've seen it. Public interest test. Now, public interest test is a balancing test that the benefits to the public of disclosing outweigh the disbenefits to the public of not disclosing. The interests of the individual are second order. So the public interest test is a test of public. Just because the public are interested, it doesn't mean you have a public interest test. Just because I'm interested in, what X is doing in there, that's not a public interest test. It's about the benefits of dissemination to the public outweigh the disbenefits of not disseminating, all right? And you have to have an argument, and you have to have a balanced argument. And there's lots of guidance around to look at public interest tests, but you need a positive public interest test, okay? Common law duty. It's surprising how many clinicians forget about the common law duty. They all come to me and say, well, I can do this under the Data Protection Act, so it's fine, it's legal. No. If you break the law, the common law, you trip on fair processing, all right? So you have to do all of these things. That's why it's called the Diamond of Delight. And if you're inside the diamond, you're safe. You can't just do Data Protection Act. Data Protection Act is permissive, all right? And we're moving towards a thing called GDPR, General Data Protection Regulation, next May. So the key things, the key message I want you to learn as clinicians is two things. We tell patients, okay? Number one message. Number two is you need some form of risk assessment if you're going to disseminate information. Have you done a risk assessment of that dissemination? So the two messages, I don't want PhDs around the room in information governance. I just want your average 11 plus, and your average 11 plus is, we tell patients. So where is the fair processing notice? Where do the patients know this is happening? Oh, well, we've got it in a rack in the CCG centre, which is security controlled over beyond 3 gates. It doesn't do the sort of the test of engagement and public and meaning openness and transparency. So be open about, we tell patients. That's technically called a privacy notice. All right.
Thank you. Good morning, everyone. So I want to talk briefly about the national opt-out, which was mentioned briefly in the video you've just seen, and talk about a little bit of how that's been approached and some of the background to that. So some quotes here on the screen which have come from the work that the NDG panel did last year in terms of working with public and patients and clinicians in terms of understanding some of the challenges we've got around data sharing. And you can see some of the quotes here, but certainly, the patient perspective, patients don't understand what we do. We do the data in the health and social care system. It is very complex, as any of us will know who work within it. Data sharing itself is not well understood and why that needs to take place. And there are quite a complex set of choices out there for individuals. There are numerous opt-outs available, there are numerous consent models. That's a very complex scenario for a member of the public to understand, and let alone as clinicians for you to try and explain to those patients when they ask. And those are a lot of the challenges we're trying to tackle as part of taking forward the NDG review, which was published around a year ago. This slide summarizes the model that Dame Fiona set out within the report. No doubt a number of you will be familiar with that. But I'll draw your attention really to kind of this middle section here. Because I think there are some myths in terms of what this report was about. But this is about the right to opt out for your personal confidential data for purposes beyond direct care. So this is not about direct care data sharing. This is about purposes beyond that. And you will see here some definition linked to that. So, we need information to run the NHS on social care. Research is a really important part of how we transform services and improve services. But the central recommendation really around opt-outs within the NDG review is very much focused around purposes beyond direct care. You will note, this, and I'll come back to this is about being respected by all organisations. So when this comes into play, there'll certainly be a responsibility on all organisations to apply that. So that will impact on everyone in this room, and that's something I'll elaborate on in a little bit. So what we're trying to do, and this will set kind of a quote from the report itself, but effectively what's been recommended is that a more simple opt-out should be made available to patients, and that the patients should be able to state those preferences online and in person. And the really important part, which I'll labour, is that this needs to be applied across the health and care system. So this isn't just something that's applied by NHS Digital, this is something that needs to be applied by all health and social care organisations. This has led us in the programme work I lead, which is about implementing this, to come up with this diagram. But so on the surface of it, it is around providing patients the ability to set their preferences, to store those preferences, and allow those preferences to be applied by organisations. But actually, under the surface of that, there's quite a few big cultural issues and shifts we need to make. We need to help you as professionals understand and be able to communicate this model and to the public and patients. We need to help the public better understand how data is used and have competence of how data is being secured within the NHS and social care. And importantly, I think about making this cultural shift. We do still use personal confidential data, and we need to challenge ourselves, I think, in terms of whether that's really needed for the purpose that we're applying it. So these are not small things to change, and I think are central challenges to us all, really, in allowing this to be implemented. In terms of how we're approaching it, we're looking to ensure that patients are informed, they need the right information to make that choice. The choice will be offered them, but they need to understand that. And given some of the complexities, that's not an easy thing to do. So we need to simplify the language, we need to simplify the way in which this is explained to patients. We also need to make this secure. We need to be confident that someone can make the preference and that they are who they say they are. And this is part of a wider piece of work under Papers 2020 around providing a range of transactions which will hopefully help improve the patient experience and also reduce some of the burden, I think, on frontline staff, because there are a lot of administrative tasks, but allowing patients to undertake some of those on a self-service basis is obviously a direction we would probably all support. As I say, we need to get the language right, and there's been some really helpful pieces of work being taken forward. So, for example, by the Wellcome Trust, which is actually about trying to get the languages that we're using a lot clearer. So we use within information governance circles and no doubt within our clinical settings, words that may not make sense or may make sense to ourselves but don't make sense to patients. And what's been taking place is a number of pieces of work to really test that with public and patient forums, so we can actually get to grips of what is the best language to use to describe what we're trying to do. And you'll see the diagram there over on the right-hand side, which kind of is trying to use a different language in terms of explaining, the term I used earlier, personal confidential data, but actually in testing personally identifiable data is something that lands better with patients. And again, around terms such as anonymous, we need to be a lot clearer in terms of what that means. So finally, what does this mean for you? As clinicians, clearly all of this work is signalling that patients want a simple explanation and those clear choices, and we need to find a way of helping you as professionals to do that. So it's about the language on the previous slide, but also making sure that it's clear how to patients where they can get more information, because this is a complex topic, as we all know. As organisations in the healthcare system, you need to understand how the opt-out is applied, what flows of data that applies to. And again, it's going to be really important that we set a very clear terms and guidance around that. Importantly, in terms of the programme of work, I'm leading, what we're trying to do is work very closely with the service to try and get this right. We recognise we need to work with the professional bodies at the national level, but also at the local level, because we recognise that this is a challenging agenda. It is a challenging message that we need to get across. And certainly, you'll see there the email address where you can get further information and contact my team. And certainly I'm here today and members of my team are here today, so again, please stop me and we can hopefully answer some of your questions. So I'll stop there, hand over to Stephen, and obviously we'll have some questions at the end.
Thanks, Tim. Okay, so I'm going to speak briefly about the context for sharing records for direct care. Now, I'm billed to speak about the GDPR, and I'll certainly have a go at that, but the slides are actually aimed at direct care and rules for sharing. So if you're hugely disappointed, just put your questions on a piece of paper or email them through to me. We've had some WebExes already, and we'll continue to support you with wrestling with how to apply GDPR. How many Londoners in the room? Good to see you. So I was involved with implementing the Connecting for Health systems into London quite a long time ago now. The narrow majority of hospitals took Cerner, and the vast majority of community and mental health took Rio. And we were working on the integration between those two some years ago. I know you may have changed your systems in that meantime. Oh, you haven't? Okay, cool. Well, I think they were very good systems. I hope you find them. Now, my current role is supporting the national teams change the spine, PDS, from being a place where things are stored and we access them. And summary care record, it's good to see Robert and Emir from the summary care record and Domain C in the audience. Moving the PDS from a place where information is held and accessed to a system which signposts locally held information. So that's the challenge nationally, and it's also to link together the innovations that you've been involved with, I'm sure, in terms of local health record sharing. And we've really just started that. It's called Domain D, interoperability, and if you'd like some briefings on that, we're just preparing ourselves to go out and support the NHS England team that has been developing those concepts. So really this is a restatement of the diamond of delight that Martin started this discussion. And for me, the crucial thing for you to take away is organisations need a framework to implement that diamond. And that framework allows us collectively to state that we are operating legally and sharing records legally. There's a lot of detail in there, and I'm happy to go through it. Key message for me, though, is that we have to establish trusted parties. And as I talk a little bit about local sharing initiatives, and please chip in, I know many of you have done some fantastic work in that space. We have to get to a stage where we can trust each other corporately. So to move from Dame Fiona's discussion of individuals and the trust of individual patients, it's how we operate multidisciplinary teams within organisations and, more importantly, across organisational boundaries. The future, as I personally see it, is federated records. Now, what does that mean? Well, it means allowing people to find information required for the specific task if it is appropriate to their role, wherever they are. And those are the things that we're wrestling with for the next generation of systems as the digital interoperability platform, as we call it, begins to go into use. And it's starting its use, it's branded GP Connect, and it's in a first of type setting in Leeds at the moment. But it's going to become grander, and more information is going to flow through it once we understand the national and gain national agreements as to how it operates. So here are some examples of local exemplars for record sharing. And can I just confirm, are you involved with those local record sharing initiatives? Yeah, everyone's nodding their head. That's great. My understanding is it's all about trusted regional brands. And trust is with individual clinicians, teams, organizations, and sets of organizations that individual patients relate to. It is less so for national organizations. I'm sure there's good reasons for it. That's my take on things. And I'm really glad that all of this is going ahead. For the most part, there is consistency in the operation of the consent model. And if you need any help, probably we can join you together. So if you put email to me, I'm happy to join you. Typically around the technology you're using, which might be the extended GP record, or it might be pooling information, Hampshire record, Leeds record, or it might be, as we're working on, this federated record, which is holding pointers to where information is, rather than holding the information itself. So I'm going to talk a little bit about the general data protection regulations, and if this doesn't satisfy you, I'm sorry, but as I said, I'm very happy to get into a dialogue and work with your teams to resolve the issues. It's generally true that other sectors, banking, finance, travel, has got ahead of health, and I'm personally embarrassed about that, and that has implications for you and your budgets, for the plans. For all I know, you may be responsible for implementing GDPR in your organisation. Is that the case? Has anyone got that direct responsibility? Yeah. So it's a heavy thing, and I'm sorry that we've put you in this position. So what is GDPR about? Well, the first thing is the Data Protection Act is quite old, 20 years old now. And as Dame Fiona said, everything is moving faster, and that includes information, use of information. So it's the opportunity the country has decided to update its Data Protection Act. And for business reasons, in other words, for the services that we sell and the systems we develop in Europe, the Parliament has decided to go down the route of implementing it. So that's the motivation. And the take-home message is stronger rights for individuals in this world of data moving around faster. Portability of data, availability of data to us as individuals, to teams providing care. And of course, artificial intelligence. The metaphor I have is Google Maps, and I was driving to Spurn Head a couple of weeks ago, just to go and see it. And I was on a B road, and suddenly the map said it was red. I'd never seen it before. The map was, and sure enough, went around the corner, policeman stopped me. Road is closed, road traffic accident. And that's the kind of interaction we expect. I mean, I hadn't signed up for that. It just happens. It's just brilliant. And I was able to find a route round, whatever. My assumption is that is the metaphor for you as clinicians in terms of having value added to the information you painfully, you and your colleagues, grind into the computer systems. And I hope that I can be part of the team that helps you to use added value. Risk stratification is obviously the thing that's currently active, but I'm expecting it to be faster, the prompts. I know Royal Free invested in Google DeepMind. Is anyone from the Royal Free here? I worked there for many years. I'm very proud you did that. Corporately, I can't really speak on the subject, but it's great that in Britain we're innovating, and I know many of you are leading those innovations. You're having to make very difficult risk-based decisions, as Martin referenced. And I heard a professor at Royal Free effectively being told off, having been told off by Dame Fiona. You're smiling. Were you involved with that?
Yeah, we're from Royal Free.
Oh, okay. And I thought the professor was very gracefully accepting the telling off. Anyway. Artificial intelligence is really important, and I'm sure it will be relevant to your clinical care. I certainly hope so as a patient. So, stronger rights for patients. The second thing is transparency. Now, if your organizations have been doing the Information Governance Toolkit and doing it well and evidencing it, you're going to be in a very strong position for for succeeding in GDPR. It's more problematic where perhaps organisations have merged and their evidence set needs to be rationalised. And I know there's a lot of mergers going on at the moment. The date for kick-off is May next year, so it's only a few months away. My assumption is that we will be given some time to meet it, and I know that that will be required anyway, even if it's not publicly stated. There is a working group, so my colleagues Dawn Monaghan, Richard Seward are working hard, and they published this week a letter to chief execs, which I'm happy to circulate to you, but it's in the public domain, you can Google it. And essentially, organisations need an action plan. And in terms of your direct care applications, your sharing of records that happen now, I'll talk about that now. Key thing is transparency and accountability. And it really goes back to the phrase that Martin used to introduce this session. Is it a reasonable expectation that your information is shared? And that's at the heart of how we legally share records. GDPR simply tightens that, makes it more clear. And we have to be accountable, both individually and as organisations, for what we share. There's this concept of privacy by design. That's something we've been doing all the while, but we may have to publicly state, or more publicly state, exactly how we deliver that, and open it up to challenge. I'm sure with the different projects you initiate, you pay people to do often what's called penetration testing, and I think there will need to be more manifest demonstration of secure handling of information. My colleagues are speaking on this subject, so you'll probably hear about the nasty outbreak of malware that took place recently. And I heard Sam from Med Confidential this week talking on the radio, saying that national organisations need to demonstrate their capacity to hold securely information. And he's right, we do need to. And we've got to find ways of maintaining the trust which I'm sure exists for individual clinicians, maintaining the trust at organisational level and at national level. Right to be forgotten, we believe there's going to be a medical exemption for that, but that hasn't been published yet, so that's an assumption that we're working with. And secondly, there's been a lot of discussion in other sectors about consent basis for sharing. The assumption we have, and this is informed with discussions with the ICO, but it hasn't been published yet, and we're hoping to move that forward as soon as possible, is that sharing will be on a similar basis as currently for the Data Protection Act. In other words, the consent model is focused on common law, back to the diamond of delight, common law and ethical, in other words, what options we care to give people because it's the right thing to do. Now that isn't confirmed, so this is speculative, and I put a big draft message on this slide. There's no question, and this is already the case before GDPR, there will be an emphasis on the wishes of patient. We had Tim go through that for secondary use. I'm sure, and Tim and I were talking about this before the meeting, I'm sure that when we get into that dialogue with citizens and patients, it won't be, their things they want to talk about will not be about sharing information. It will be about, I don't know, what kind of treatment they want, where they want it, car parking, travel. So, although legally we have to cover off consent for sharing for secondary use, consent for sharing for direct use, and I'm sure we will, I think when we get down to that discussion, we're going to have to find a way through their own priorities and where sharing fits within that. There are various strategic commitments to creating portals. So in NHS Digital we are planning patient portals, and we know also you locally are planning portals. So we'll have to navigate how those portals coexist and thrive together. Thank you.
Brilliant. Thank you very much. Right. Great. We've got more time. Done well. Right. Over to you for questions, answers, see where we go. Lots of hands, great. I'm just going to go work my way around the room. We'll get all there. Right, go.
Stephen, all for yourself. I'm Jeff LaBelle, I'm the CCIO of the same side. Now, we share data across our area.
Yeah.
We have DataWell, which is a bit of a data sharing for clinical discharge letters, pathology results. our pathology results of one single blood test. It's in our laboratory system, it's in our EPR, it's at our GP, it's at the referral lab that did it, now it could go in Datawell, 5 different places where one result lies. Is the NHS getting lost to the simple question from a patient, where does my patient record exist? When it's scattered across multiple IT systems. So the question, the right to be forgotten, please can you delete that blood test?
Well,
Where does it live? Sorry.
My view currently is that there will be an exemption for medical purposes for the right to be forgotten. Obviously, that could be proven wrong because it isn't confirmed yet. But the general point of we as citizens, we as patients, our records are multiplied in backup systems as well.
Yeah.
Yes, that is the nature of information processing currently, and NHS Digital and NHS England and nationally, we're moving to the strategy of working out how to thrive in that context. You know, how I conceive of it is federated record keeping with pointers to where information is held, and the management of messaging as required. You know, so that messaging may be generated by a direct patient contact or an audit requirement will allow that information to be made available back to where that is required. So I think that's the game we're in. I guess I'm just saying, yes, you're right. It's difficult. I think we are developing technologies which are relevant. They will remain hugely problematic for people like you on the front end of both delivering care and also planning.
Yeah, I have got an A to Z index at Tameside of every health record, so there's 350 individual items. And I had a primary record, a secondary record, a tertiary.
Yeah.
I've now had to create a level of 8 possibilities of where that record could live. So in the event of GDPR and a patient says, can you delete that discharge letter?
Well,
It's a big job to actually trace it and follow it through the roots of IT and cyberspace to delete each one.
there is a right to be forgotten already in DPA, yeah, but it's exceptional.
Yeah.
So you already have that challenge.
Yes.
I know at UCL I was involved with years ago, someone having successfully got a court order for the deletion of their record, and it was very, very difficult to demonstrate because of the multiplication of holding a record. Yeah, I mean, hopefully technology will make it easier, question mark. What we're doing in a positive sense is developing this portal concept for patients, and the planning assumptions we have is that will give individual patients, if they have the mind, to access their own record and see where it is held and have it available to view. Also to see who has seen it. And that's part of the new architecture that we're seeking to develop and we wish to develop with you. So you're absolutely right. Thank you for making all those very good points.
Sheffield, diabetes specialist. I'd like to ask about where the patient's desire to share information is overridden by clinicians. I'll give an example of the National Diabetes Audit, which has been going now for probably 10 years. It was initially voluntary primary care, then it was mandatory, and then more recently it's been changed so that primary care has to opt in to giving this information. Patients within diabetes organisations will express the wish to share that information. In a long career, I've known no one who does not want to share that data, and yet we're now in a situation where maybe because of pressure of work, rather than not wanting to share, primary care is not contributing that data. So why is that? Why put in place those sorts of barriers?
Do you want to take this, Martin?
Yeah. So, I don't know the detail, Adrian, in terms of the precise example, but the example you've given is, should a clinician's decision as data controller in the case of a general practitioner, or should the data controller decision override the patient consent decision? So my issue is, first of all, that's an ethical challenge and a professional challenge. So I think that is an issue that should be discussed by the Caldecott Guardian for a start off, just on a practical sense. as a national Caldecott Guardian, if the patient wants to share their data for an audit purpose, an audit is a respected purpose by the General Medical Council, I'm struggling as to why an individual GP has made a decision not to share. So that there's a conflict there, and I don't know all of the details. What I suspect is that general practice has, I don't know, N,000 people in it, and they do not have a mechanism by which we have a opt-in, if you like, a data donation principle. Now,
But they do, Martin. I mean, the point is that they're being made to do it annually now. So they've done it 1 year, and then they've got to do it another year and another year, and you know they've got a lot of pressure on them.
yeah, so I'm one for patient power because I believe it's justifiable and I believe it's informed. So consent should trump bureaucracy. Okay, consent should trump technology. The issue is how to make consent available to the general practice. The issue is it's not being raised as an ethical issue, as a practical issue, as a technical issue. What I'm trying to think through, Adrian, is process. How would I get that? So in process terms, if that's what the diabetic patients have said and think, and I've got no room to doubt you, I think they should put something in writing. That's the first thing, and I think they should. I think that should be discussed with the GPs who have decided not to conform of where that stands in the Caldecott guidance. I would probably take it to the National Caldecott Guardian Council for it to be discussed in all its detail. If the National Caldecott Guardian Council feel actually there's a problem here with professional activity not sharing where the patients do want to share, I think that is an issue that should be taken to the National Data Guardian and discussed. So I'm thinking of a process rather than say the GPs are wrong, the patients are right. I'm not clear enough on all the nuance. So what I'd like to say is, if there is a general view from diabetic patients through their diabetic patient organisations, they should make that known. They should make that known to the National Caldecott Guardian Council. That issue should be discussed. If there is a real live issue, and it is thought to be problematic, and the National Caldecott Guardian Council can't solve it, I think it is an issue that they could choose to take to the National Data Guardian for a view in terms of how could we solve that particular problem, and in solving that problem solve other problems. So I'm giving you a process answer because what I don't want to do is give you a definitive answer when I don't know all the detail, if that's all right with you. Yeah, go there.
I mean, that's a very interesting response to a very interesting question. Rob Alcock, I'm CCO and from Gateshead, and I'm a chest physician. What you've just described, for me, sounds like about 2 weeks' work.
Yeah.
To solve one little bit of flow from one GP practice. And that kind of issue is just the bread and butter of what we're facing.
Yes.
And you know, you kind of told us the kind of, you know, the right thing about royal free and deep mind and a bit of a smile. Those things which they hit the news frighten the hell out of our trust board to the extent that they then say, don't do anything. The reason why your GPs behave like that, I'm pretty confident with the same reason our GPs have suddenly stopped making any progress, is because they've read in the news about System 1. And there has been a complete absence of clarity of guidance from the centre to tell them what to do.
Yeah.
And so everybody's terrified they're going to get a 50 grand fine from the ICO if they share anything. What you do in response to that is you haven't got the time to do the 3-week process. You just say no, because 50 grand is a lot of money.
Yeah.
And
So
what we need is total clarity quickly from the centre to solve these things.
right. So if one has 2 groups, let's call them doctors, just for argument's sake. So there is a group of doctors called general practitioners. They have a Royal College, they have a joint GP-IT committee, right? So it is possible to, for example, for the national audit, for us to be directed to require the data. We could do that. What's needed here is a professional discussion between the colleges. So one is sort it out, Martin. Well, it's not in the job description, which I'll probably try. because that's the nature of the beast. But the issue here is this is about conversations within a profession where two bits of the profession are disagreeing with each other. And what I'm trying to elucidate here is, you said it's fairly simple. It may not be as simple if you're sat in the general practitioner's space to make that decision. And all I'm saying is we do have to get a process, but fundamentally different groups, different bits of our profession are fundamentally disagreeing about something, if that's what you're saying.
I don't think they are
No,
fundamentally
agreed.
disagreeing. It's the
No.
process that's causing the problem.
They don't know what the
and the
rules are.
bureaucracy that they have to go through to do it. That's causing the problem, not the actual fundamental understanding of what they want to do.
All
Okay.
professionals agree that it's absolutely ridiculous and everyone wants to
Yeah,
share.
yeah.
There's complete unanimity on that. And there's complete unanimity that we always did share what the hell's the problem.
Yeah.
The difficulty is nobody's quite sure what the rules are.
Yeah.
And suddenly you kind of randomly a fine applies.
Right, no. There hasn't been any fines for sharing for direct care.
What the perception.
Okay, there's lots of perceptions.
Yeah.
But what Adrian presented to me, in all fairness, was the patients consented and the GPs have not consented. That's how he presented it, right? So the GPs have to press a button, right? If the GPs are choosing not to press a button, I'm not prepared to stand in front of an audience at a question and say the GPs have got some fundamental fault.
Yeah.
There is something that's stopping them pressing a button. Now, there's two ways of doing that. One is to not give them the right to press a button. Fine. The other is that they would press a button, because why wouldn't they? Because that's what patients want. So all I'm saying is, in this situation, I don't want to come down and say something inflammatory against one part of the profession who may be very balanced against another part. And all I'm saying is I'm trying to get a process to resolution set.
Just take that on a little further, and I'll bring on the second point if you don't mind. I think at the moment there's a culture of fear in the NHS.
Yes.
They're getting it wrong.
Yes.
And they're the easiest, and what you're hearing across the board, not taking any specifics to take away those, the default is no.
Yes.
So if there's a question, people say no.
Yes.
And I suppose what people in the room are asking for is a hotline
Yes.
to say, I'm sure that's rubbish.
Yes.
Can I go higher to actually get some clarity? Because
Yes.
nobody is prepared to make the decision to say yes.
Yes.
And that's the position we're in, and that's what you need to hear.
Yes.
And that we need who to email, who to make this clear, that we can actually do something. That's number one.
Yes.
The second point I got is sharing information across IT. I'm talking about social media in terms of FaceTime, talking about Skype.
Yeah.
We work with large geographies now
Yes.
because of cutbacks and
Yes.
etc. It's very hard to get face-to-face meetings, and we're always blocked in terms of how we communicate. We can have an audio link, which is not very good. You know, if somebody's left the room, you don't know if they've fallen asleep on the other end of the line or they've been cut off. We've got no idea. I just don't know why we can't use the social media which is there in terms of FaceTime, Skype, especially when we're not discussing patient identifiable information. We're still blocked. Probably not, but nobody makes it say we can use it. But again, even MDTs where we are using patient identifiable information, we need to find a way of facilitating that.
Yes.
Because the NHS is totally reliant on using new technologies rather than all physically coming to meetings. It just is not cost effective. And taking it even one step further,
Yeah.
the patients, the GP, secondary care, how do we actually make these flows happen?
Yes.
And I think what I'm hearing in this room is nobody's clear. I'm just going to stiff at this new thing because basically people won't understand this and so the default will be no.
Right.
And so we really struggle. So what we want is a clarity to say, how do we get to somebody who can make decisions to say yes? It's actually their pay grade allowed to say yes. There's no doubt that nobody's the person.
Right. So information governance, their job is to say, you may not be able to do it this way, but you can do it this way. It's not to say, no, you can't do it that. I know where you're coming from. This is part of the culture change. You are Caldecott guidance, you should have one. How much does the Caldecott Guardian get involved? How much does the Caldecott Guardian ever ask for advice? This is bread and butter. You have to stand up and you have to make judgments. You may get them wrong, you may get them right, but you're a doctor, you're a nurse, you're making life and death decisions every day. Information transfer is no different. It's absolutely no different. And you have to make those decisions. You can't rely on oh, my technical advice is no. My technical advice is, yes, no that way, but give me some technical advice as to how I can do it legally. And that is a culture change in information governance. It does have to take place. I agree with you. But equally, we as professionals have to stop using it as a convenience for not doing things. So in some of the areas that you're talking about, there are ways forward. So people were saying to me the other day, the patient wants me to send them a letter by email. IG says no, because they haven't got an NHS.net account. Forget it. The patient, look, you haven't got...
Just that,
Yeah.
to the UK,
Yeah.
would be transformational.
Yes.
If you just tell everybody that,
Yeah.
it will make a massive difference. Because everybody out there thinks that you're not allowed to.
You can't.
Because the IG officer will tell you you can't.
If the patient has consented, I'm going to send you my letter, right? The easiest way, I had an academic last night, at the Royal College of Surgeons doing exactly this debate. I said, look, if a patient's found your academic email account and has written to you and said, can you tell me about the test you did or the operation you did, you write back and say, is this really you? What operation did I do? And are you really content? And the patient comes back. You've got prima facie evidence of affirmative action, reflection, information given in good faith. Yes, you can do it.
Well, that's really helpful. Let's broadcast it.
All right, okay.
I'm going to ask Martin to repeat that the next session, so Martin, we have to go.
We have to go on to the next session. All right, thank you very much.
Thank you.